I'd like to, for the live case, we have one more presentation, Mechanical Thrombectomy, the posterior circulation after the golden hour by Deniz Bulja. It's a very important presentation. The floor is yours.
Thank you very much. I want to thank the organizer for the invitation and to extend my congratulations for a wonderful organization of the Congress and to congratulate on the occasion of International Women's Day all the ladies in the hall. Topic of my presentation today is mechanical thrombectomy in posterior circulation after the golden hour. Thank you, Nuri, for this presentation. I have nothing to disclose, and we can say that usually vertebral basilar occlusion results in neurological catastrophe for the less fortunate ones, and fortunately, however, it is less common. It accounts for only 10% of large vessel occlusions and only 1% of all ischemic strokes. So here we have an image of a lady with acute vertebral basilar occlusion. It happened a few days ago. Unfortunately, she's dead now. So among patients with vertebral basilar occlusions who present with moderate to severe clinical findings, up to 80 or 90% will die or remain with severe disability, whatever you actually do, despite best medical care, like in this case here. How does it happen? There are different mechanisms who actually make this pathology. Either it is atherosclerotic in nature with later thromboembolic complications from the rupture of the plaque, or it is purely embolic in origin, in etiology. In most of the cases, you find emboli from the cardiac origin. So symptoms are what actually makes this pathology difficult to treat timely. In most of the cases, you have patients with varying and ambiguous symptoms. If you encounter 5Ds, then you're lucky. The patient will get imaging quickly and perhaps treatment as well. In rarer cases, infrequent cases, you have sudden symptoms which may suggest an embolic etiology, which usually results in better results from thrombectomy. So why is this? Because face-arm speech test actually doesn't work in most of the patients with vertebral basilar occlusions, and NHSS actually performs poorly in predicting posterior circulation stroke. That's why you have many authors suggesting post-NHSS for these patients with extra points for truncal ataxia, dysphagia, and abnormal cough. Patients present as just with nausea, headache, or vertigo, or they're in coma. And according to Burns and authors, this actually substantially delays the diagnosis of vertebral basilar occlusion. He compared groups of the anterior stroke and posterior stroke, and the time difference is actually staggering. It's 7 hours. So what can we do? We can do nothing, which is a bit nihilistic. We can go with the IVT-PA within the first 4.5 hours. It has been shown that it decreases mortality up to 50%, and of course there's mechanical thrombectomy, which is readily performed 6 to 8 hours, and increasingly now beyond this cutoff. What is the consensus regarding the treatment? Is it PC aspects? So you have different trials suggesting it should be 6 or it should be 8. There's a general consensus about Pons midbrain index. It has to be 2 or less. And at what time EVT golden hour ends, nobody knows. It can be up to 24 hours, as I suggested. So it was easy for the 2015 studies of the anterior circulation, and they actually, purposely excluded the patient with the basilar artery occlusion because of the poor results which would actually make these trials less significant, and we know that they are actually working. So what about vertebral basilar occlusion trials? There are many, largely on Asian population, like BEST and BASICS, and BEST and BASICS actually failed to prove that there is a statistical significance of treatment of these patients in regards to best medical treatment. So we have pretty much same figures from the Dutch study, basic study. It's only 44 against 38% of the patients. And if you look to the MRS scale, you can see that these studies actually increase the number of the patients with MRS 5, which is actually adding substantial cost to national health fund systems. The newer studies from 2022 showed that there is actually significant benefit. How? I don't know. So tension actually recruited the patients up to 12 hours and showed 46 against 23% in the control group, and the same, almost the same figures were actually reached in the Bauchi study, 46 against 24%. So if you look to the MRS here, you can see that actually they decreased the mortality and they decreased MRS 5 patients as well. So it works actually by these studies. And of course, if you look times from stroke onset to groin puncture to revascularization, it actually varies from 7 hours in the tension study to more than 13 hours in the Bauchi study. So these are some cases that we actually performed. This is the first case that we performed in the posterior circulation. It was a kid, 5 years old. He fell from the chair in the kindergarten, and few hours later he received CT, and then early in the evening MRI. So past 10.5 hours we actually entered the angio suite around midnight. It was super easy, only 3 passes of Sophia 5 French because of the vasculature, and the end result was MRS 0 at 90 days. Cardiac origin of emboli was discovered later. Another one, easy again, with the cardiac emboli origin, NHSS was pretty high at that time. However, it required only 1 aspiration to pick up everything with a relatively good MRS. In this case, because we have proximal basilar artery occlusion and possible, of course, atherosclerotic change at this site as a culprit lesion, we had to use aspiration and stent retrieval. So all in total 3 passes. Angioplasty at the end, however, the MRS of the patient was not that good at the end. This patient was treated 13.5 hours after stroke onset with the radial artery puncture because of the atherosclerotic changes in both legs, actually. Both internal common iliac arteries were occluded. So it was easy actually to access, to aspirate, to go with the stent retriever, pick up everything, and angioplasty. However, this patient didn't do well. Why? Because of the high cerebral infarction burden. Actually, PC aspect was high before the procedure, so he actually passed away a few days after the thrombectomy. Next patient, this was stroke onset was 9 hours, relatively nice result after stenting, And this is his CT from February this year, so it shows only infarction in the cerebellar region, so the patient actually did well at the end. And this is the last case that I'm going to present. It's about a patient with iatrogenically, almost iatrogenically caused basilar artery occlusion. So he had stenosis of proximal basilar artery portion. We angioplasted it, and all we actually achieved was snowplow effect, as you can see on the MRI here. It was he had severe symptoms at that time. We decided not to stent him, but to continue with the aggressive medical treatment, and this is the result from October. So it has like 50% of stenosis of basilar artery, so everything went well at the end. So in conclusion, we can say that these randomized trials actually yielded mixed results, and questions still remain. There is a need for uniform prospective studies that are using standardized clinical assessments, and it would be advisable to select patients with more severe stroke symptoms who have lower infarct burdens, according to my experience. And of course, I think that we can all agree here that the reperfused basilar artery is better than the occluded one for the patients with some viable brain to save. So this is image of all interventional radiologists in Bosnia and Herzegovina from my congress that we organized last November. This year we will organize the aortic aneurysm repair workshop at the end of October, and I will communicate everything with the Bulgarian Society of Interventional Radiology. Thank you.
Fantastic, great presentation. Just make one comment. You talked about the time window, and I think that's one of the problems with the basilar artery, that we have those fluctuating symptoms. So when is the actual time of onset? And was it 2 days ago when the first symptoms was it when the patient became drowsy? So for me, usually the time window starts when the patient becomes comatose. And I think another part which again impacted a lot the previous studies, next to that patients were not consecutively selected, and the studies went over years and years, and the big variety of the anatomy and the collaterals. And I think that is much more than we see in the anterior circulation. And I'm not just talking, is there an artery of Percheron, but is there filling from the anterior circulation as well. So I think in the assessment of the patients to choose and which one could have done without treatment, we really need to focus on the collaterals, a lot on the collaterals.
I completely agree with you.
Right. Thank you very much.
I would like to make also a comment on the comparison of the older and the new trials. So one was the slow recruitment. The other problem with the old trials was basically that you had a very high crossover rate. So over 20% crossover rate. And if you do that, so if you randomize somebody for conservative treatment and then you do the thrombectomy anyways, you won't be able to demonstrate the difference. So that was one major problem. And the other major problem was that they were actually recruiting even patients with low symptoms. So basically who were had very mild symptoms, low NIHSS. And the big difference between the Chinese, the Bauche and the attention trial is that they only recruited patients with an NIHSS of 10 or more. So they had to have severe symptoms, and they were extremely diligent. So somebody who got randomized to conservative arm remained on conservative arm. And this is how you could actually demonstrate. I would like to also reflect the fact that you've been using radial approach. I'm really happy about that. We are using it almost all the time now also for the posterior circulation, because it's much more accessible and it's sufficient to have a 6 French guiding in the vertebral artery. The important thing is that before you go into the procedure, you check which one is the dominant one, and if it's necessary, you need to puncture the left radial, and then you can go up. So always go on the right, on the appropriate side, because from the right you cannot cannulate the left.
That's why actually we always can from the aortic arch to the
So, but then you can use it. And another point for the stenting. So the difficulty of the whole basilar thing is that you have much more atherosclerotic disease. So you have about 30% who have plaques, And in our practice, we are using actually coronary stents to treat those lesions, and we have very good results with them because the anatomy, the access to the basilar artery is easier than the anterior circulation, and coronary stents actually do make that road easily, and you can sufficiently use them. The important is that you undersize and overinflate, not to have rupture of the basilar. So you use, because coronary stents need to be inflated always at least to their nominal, otherwise you would have stent thrombosis. But if you're unsure, you should rather have a smaller one and then use a higher pressure to overdilate, and then you get the best results, basically.
In this case, we used, in the stenting case, we used actually the only C approved at that time stent for cerebral circulation, you know, the company. So
yeah, I mean, this is an off-label use, it's not a question, but it still works well.
You know, and I think it's a good idea actually to use coronary stents, and I heard about
Thank
that.
you.
We would also routinely use coronary stents for this procedure, not just because of the price, but because it's just there's much more variety you can choose from, easy to handle.
Okay, thank you.